Hi guys. Hello everybody. Guys, say hi in the comment section. If you can see us and hear us, please say hello in the comment section. It lets us know that everything is working before we get started. Also, if you've got the link to today's session, please share the link to as many people as possible. Invite as many friends as possible to join our session. Say hi in the comment section if you can hear me and if you can see me. Hi guys, if you can see me and hear me, type hello in the comment section. Type hello in the comment section if you can see me and hear me.
Sorry, my computer decided to have a bit of a mare on itself just then.
It's okay. Welcome back. Guys, say hello in the comment section. It lets us know that you can hear us. It lets us know that you can see us. Say hello in the comment section. Also, share this link to as many people as possible. Share this link to as many people as possible to invite. If you're on any WhatsApp groups or Telegram groups or Facebook groups or Instagram, you can invite as many people as you want to the free session for the upcoming exam. Okay, so what we'll do, we'll get started, and obviously people can join us when they are ready. Guys, we have an absolute legend in the building. We have Sureena, who is, well, you've worked in community pharmacies, isn't it, Sureena? You've done community, you've done some tutoring, and now you work for HEE. Guys, please say welcome to Sureena in the comment section. Guys, say welcome to Sureena in the comment section. It's lovely to have you on with us. You are welcome to today's show.
Thank you so much for having me.
You're welcome, Sureena. Guys, say welcome. Type welcome in the comment section. If you can see my message on there, just type welcome in the comment section to Sureena. It's really lovely to have her on today's session. We're going to cover advice for trainee pharmacists, important advice. We're going to cover advice for trainee pharmacists, and we're going to go over some clinical content as well. So please get your notes out, get your BNF, get your pen, so you'll be able to take down some notes. And please feel free to get involved. Ask questions. Ask as many questions as you like. We'll try our best to answer as many of them as possible. And if there's anything else, you can sort of email me later on and I can try to answer those questions. So before we get started, let's say hello to people in the comment section. I have Romina. Romina is in the house. Hello, Romina. I have Firami. Hello, Firami. Queen Catway. Queen K. I'll call you Queen K. Hello, Queen K. Rebecca. Rebecca is in the house. Hello, Rebecca. I have Nias. Is that Nias? Yep. I have AT. I have Quaco. I have Gloria. Hello, Gloria. I have Sadia Khan. Guys, welcome so much. Welcome to you. And thank you so much for joining. Like I said, if you want to invite more people, feel free to share the link to today's session. All right, so let's jump straight into it. The first thing we'll talk about today is important advice for trainee pharmacists. So I'll hand this over to Sureena so you can go over some of these questions that trainee pharmacists tend to have during the trainee pharmacy year. All right, so I'll hand over to Sureena and let's get started.
Thank you. Hope you can all hear me okay. So the first question is how to make the most of your training site. I think a big piece of advice I would have is be proactive when it comes to your whole foundation training year as a whole. The more that you make out of your year, the most you'll get out of it as well. So this means getting involved in as many services as you can, getting as much experience as you can, getting as much exposure as you can. Speak to your designated supervisor or pre-reg tutor, see what opportunities are out there that you can get involved in. So for example, could you be a smoking cessation advisor? Is there a particular service that you could help support within the pharmacy? Are there any cross-sector opportunities that you could have? The more exposure that you can do whilst you're a trainee will put you in a better position for when you are a day one pharmacist. I'd also say in terms of networking, that's a really good way to get the most of your training site, because you'll be working with a multidisciplinary team. You might be working with different members within a GP practice or a primary care network, within the community pharmacy itself. If you're working within community pharmacy, there's a lot of networks that will be out there. And so even a network like this and being able to connect with each other on here is a really great way to make use of your training site. And it also helps with any sort of questions that you may have, queries that you may have. By forming those smaller groups and being able to support each other and have that support network can be really, really beneficial. So another question about how to combine revising and working full time. And that's a question over the years that I get asked a lot. If not, it's probably the #1 question that I get asked. So much so that I actually have a YouTube video on my Sureena Speaks channel, which is called How to Revise. So some of the elements on which I think you can combine revising and working full time. First and foremost is actively revising. So what do I mean by that? Well, let's take something really simple, such as when you're dispensing a prescription. Now, you can choose to just do that blindly, dispense what's in front of you, and then give it to the pharmacist to clinically check. Or you can choose to actively revise. So take a look at that prescription. Is it an FP10? Is it a prescription with controlled drugs on it? What is it? A dental prescription? Is it a private prescription? And then consider what legalities surround that particular prescription, especially if it is a private prescription or controlled drugs or veterinary, etc. Then look at what medicine or medicines have been dispensed and consider, is this appropriate for the patient because of their age group? Does this patient potentially have any other comorbidities? What if they're hepatically impaired, renally impaired? Is this medication going to affect them? What cautions or contraindications are there? Are there any counselling points that I need to make this patient aware of? And so by doing that, you're actually revising whilst you're at work and you're testing your knowledge. And if actually with any of those questions, you can't answer them, that's fine. Jot it down. And then when you do get that time when you do have a moment to revise, you're then really pinpointing and being specific with your revision so that you're highlighting and focusing on those areas that maybe you're a little bit weaker in and actually need a bit more focus on. I think in terms of, and that's a good way of also identifying where there are gaps in your knowledge. By all means, also identify where your strengths are, because you don't want to become complacent and leave those elements. But at the same time, really try to structure your revision in such a way so that you're focusing and prioritizing on those areas that maybe you struggle with a bit more on. Also, when you're actively revising whilst you're at work, if, for example, you're in a community pharmacy setting and minor ailments is an area which you aren't particularly confident in, then try and get exposure onto the healthcare counter. Have a look at what medicines there are around you. Take something like mebendazole, for example, for threadworms. Have a look at the packaging. What is the indication? What age restrictions are there? What counselling points should you be giving? Again, you're utilising your time most efficiently whilst you're at work. Something which I found really helpful to do was actually make posters. So something like the GI system, I'd create a poster on and I'd stick it in an area where I would look at very often. So for example, on my wardrobe door, and that way when I would be getting ready for work or when I'd be coming home from work, it would force me to look at the content that was on there. And at least that way I was then able to keep revisiting those particular areas and keep reinforcing that learning. It's about how can you utilize your time in the most efficient way. And in terms of like revising and working full time, I know an area that a lot of people do struggle with is calculations. And I too was someone who really did not like calculations. And with calculations, actually doing a little each day can massively benefit. So don't try and leave that to the very last minute because you might think, oh, I don't like calculations. I want to avoid that. I want to wait till the end. Try and do a little bit each day and that will help you. So next question is when to start preparing for the assessment. Well, really and truly, this whole year is about not only preparing you for the assessment, but also preparing you as a confident and competent day one pharmacist. So when to start preparing for the assessment, you're probably already preparing for it. You might not even realize. So again, whilst you're actively revising at work, all of that is going to help towards the registration assessment. And all of that is preparation for the assessment as well. In terms of how to get extra support, try and seek this out from your designated supervisor or your pre-reg tutor. If there are any other healthcare professionals that you're working with who can give you that support, other trainee pharmacists, such as on this network, for example, they too can be really beneficial in helping support you because nobody else knows what you're going through except for those that are in the same position as you. So finding and seeking those different networks can really help. There are also amazing charities out there as well. So something like Pharmacist Support that is accessible and available for trainee pharmacists. They provide advice on mental health. They provide financial help as well. And so if there are any areas that you're struggling, and to be honest, even if you aren't struggling, do have a look at Pharmacist Support because you'll find an abundance of resources on there that will actually help you throughout your training year. So those are the different ways that you can get that extra support. And also through different network, like we're saying, networks such as this with myself, with Micah, there's ways that we can support you too. So do feel free to reach out. This all does help in terms of smashing the exam. And what I've noticed with a lot of people is that actually it's a confidence thing more than anything. You end up psyching yourself up before the exam. And then when it comes to it, you get into this sort of state of frenzy or fear. But actually, when you can instill that confidence in yourself beforehand, that can really help. It's very hard to see the progress that you make each day, but think about how much you've learned now and how much you've grown up to this point and compare it to when you first started in your foundation training year, whether that be in July or September or October, and think about maybe how overwhelmed you felt back then, but actually how much you know now. All of that confidence does really help. And because you would have learned so much during that time, that too will help increase that confidence. That little bit of self-belief can go such a long way and can really help towards your attitude in smashing the exam. So all of these have been hints and tips to help you pass the exam. Now, in terms of when you become a registered pharmacist and beyond that, there's certain things that you might want to consider. I'd really, especially after you've just sat the exam, I would really recommend that you start looking at what services you can be accredited in. So look at what advanced and enhanced services that are there and that are available. Speak to your tutor or your supervisor to see what advice they can give too, because that will get you ahead of the game and in better stead for when you are then a day one pharmacist. You might also want to look at Health Education England's newly qualified pharmacist pathway, and it acts as a stepping stone to enhance an advanced practice, and it also provides another way of a mechanism of support. So that might be something you want to look into as well. I know I've said it a lot, but again, networking really does help, especially as a newly qualified pharmacist, having those WhatsApp groups and asking your peers, oh, I've come across this situation or I've come across that situation. What advice would you give? That can really help. Even as a qualified pharmacist, that really does help. So keep those networks going as a day one pharmacist. And also think about those practical elements as well in terms of any insurance that you may need, signing up to locum agencies, if that's a pathway that you want to go down. There's all those particular elements that to look into as well. I do have more on this on my YouTube video called, I think it's called Being a Day One Pharmacist. So do have a look at that, and another one on locuming as well. So those videos will help you in terms of being that newly qualified pharmacist and how to empower you and how to have that confidence in being a newly qualified pharmacist as well.
Sureena, thank you so much. I just wanted to ask a couple of questions as well. With trainee pharmacists, once they sit the exam and they get on the register, are they able to work for HEE, Health Education England? Because obviously one of the good things about getting on the register now as a new pharmacist is there are loads of options available to you in terms of career pathways. So when we start the exam and we go on the register, most people ended up in community or hospital, but now there's more options, isn't there? You know, GP surgeries, PCN. Can you talk to us a bit about those options that are now available to newly qualified pharmacists, and if they can work for Health Education England, which is where you work at the moment?
Yeah, no problem. So like you said, there are so many opportunities for pharmacists that I think we sometimes forget that, because let alone being a pharmacist, actually having your MPharm degree can be an incredible key to open so many different doors for you. When we talk about things such as going into industry, we say industry like it's one entity, but actually there are so many different pathways within that. There's research and development, there's clinical trials, there's medical writing, there's so many different avenues. And if you have a passion for something in particular, say for example, you have a passion for writing, actually you could combine that passion and your pharmacy experience and knowledge to go into something like medical writing or medical journalism, writing for the pharmaceutical journal, for example, or chemist and druggist. There's so many different opportunities out there. In terms of education, there is, again, a lot of different routes. You can work for training providers like the National Pharmacy Association, ProPharma, Buttercups. You can work for organisations such as Health Education England or NHS England. With these particular roles, though, experience is required in terms of having that background experience of being a qualified pharmacist. So if you have been a community pharmacist or a hospital pharmacist, being able to bring the experience and stories that you have there into your education role really puts you in better stead. So there are roles that are available, usually for Band 6, Band 7 onwards. And I would recommend that you look on the Health Education England website. If that is something which you want to look into, have a look on their website, because they do post job opportunities on there. And also LinkedIn as well is an amazing place to see what roles are available, what opportunities are available, because there are so many things that you can do with your MPharm degree, and it is just growing, especially within sort of the GP sector, PCNs as well. There's loads that you can do out there. So really explore, and I'd really recommend researching what best suits your needs and where it is that you can see yourself.
Thank you, Sureena. Next question is about the pharmacy profession. So some of the questions that I get from trainee pharmacists around, what they hear about pharmacy as a profession, from the media, from some people who are already qualified and are working as pharmacists already. And some of it does sound, doom and gloomy, doesn't it? Because some people are working in areas where they're facing a lot of challenges. To be fair, the entire NHS is facing a lot of challenges at the moment, as whether it's staff issues or financial problems, etc., etc. But what can you say to somebody who is still thinking, is pharmacy still a good profession for me to get into? Is it worth it, etc., etc.? What would you say to them? Because as I said to you, my younger sister, I literally advised her to study pharmacy, and she's at the University of Reading, which is the School of Pharmacy that you went to. She's in her second year at the moment. So I do see a lot of potential in the profession, and the fact that you can get into so many different areas as well. But what do you have to say about people and how they feel about the profession from your point of view?
I mean, for sure, there's no secret that pharmacy is definitely underfunded. I think it goes back to there being and finding those opportunities within pharmacy and which areas are of most interest to you. The reason why I stayed within pharmacy and have stayed within pharmacy a few years after qualifying is because it is a really stable profession. There will always be a job available, and because there are so many different sectors you can go into, you can always try and dabble in one. If you think that's not actually for me, let me try elsewhere. If that isn't for you, try elsewhere. Sometimes you have to figure out what it is you don't want to do before you figure out what it is that you do want to do. And with each of those roles, there's so much experience and so many networking opportunities that you can take from it. It can then help you navigate into that next role which you want to go into. So like I was saying about that MPharm degree, and that MPharm degree being able to open up those opportunities for you, I would say with pharmacy, it is stable, it is a secure profession as well. Even say, for example, you're not in a full employed role, you can always be self-employed and go into a locum role instead. You can be a bank pharmacist within a hospital. There is always that knowledge and safety in knowing that, okay, from a financial perspective, actually, I will be secure in that respect. And I don't think many professions can actually say that. So that would be sort of my own personal thoughts and feelings on that.
Thank you. Thank you so much. Yeah, so I was just going to add what you said is spot on. I was just going to add as well that one of the great things about this profession is your ability to sort of move around and find what's comfortable for you. Because I've had people who worked in community, got fed up with community, went to a GP surgery to work as an IP pharmacist, for example, and they didn't really like it either. So they ended up coming back to community, you see. But I think the important thing is that they've had a chance to sort of move around within the profession to see, what's better for them. Because sometimes you think the grass is green on the other side. You try it and it's not as great as it seems, because everyone has what's better for them. But the most important thing is, whatever you do, please stay safe and healthy. Stay safe and healthy. If you're working somewhere and it's not safe where you're working, you need to do something about it. You need to raise your concern. You need to speak to somebody, whether it's your superintendent pharmacist or even the GPHC, whatever authorities you need to speak to. Please do that, because if you're not safe, then you can't safely check medication and give it to somebody else. Does that make sense? So you have to be safe wherever you're working. Is absolutely important. There's no compromise. You can't say to somebody, oh, something happened because I didn't have enough staff. There is no compromise. You go be safe to be able to safely look after other people. Number two, your mental health. If you're working somewhere, you're not happy, you're depressed, you have to speak up. You have to do something about it. Pharmacy Support is a great charity for pharmacists, pharmacy trainees, pharmacy students, even family members or pharmacists as well. So please reach out. Do something about how you feel, because like I said, if you're not happy within yourself, if you're not well, you can't look after unwell people. So please do something about it. If you have to move somewhere else, move. I worked in a couple of places that I didn't really feel safe in the past, and I ended up moving, and I'm a lot happier because I made that move rather than just sitting in that place and feeling very unsafe and unhealthy. Obviously, raise your concerns to help people improve things, but if you have to move to other parts of the profession just to make sure you're happy. All right, so let's look at a few more questions. I have a question from Geeta. Geeta's asking, says, do you need to know the doses for every drug? I'll answer this one, Geeta. I'll answer this question for you. Do you need to know the doses for every drug? No, you don't need to know the doses for every drug. Some drugs you need to know the doses. The easiest one, top of my mind, is simple analgesics like your paracetamol and ibuprofen. They will ask you about that. Most times in the exam, they ask about the doses of paracetamol, the doses of ibuprofen. Then your common antibiotics as well. So when I did a free session a few months ago, I said the three important ones you need to remember with your antibiotics are amoxicillin. Remember your amoxicillin doses for children, especially. They like to ask about children. Remember your phenoxymethylpenicillin, for example, the 250 milligrams /5 mil starts from children who are 6 years and above in general, unless obviously there's a weight factor to consider for a child less than six, then it might be on the 250. But in general, phenoxymethylpenicillin 250 /5 mil is given to children from 6 years old and above. Your nitrofurantoin, the GPHC likes to ask about nitrofurantoin as well. Which dose is suitable for men, which dose is suitable for women, etc., etc. So those three are some really important ones to remember as far as your antibiotics are concerned. And then you need to know the doses for the novel oral anticoagulants. So your edoxaban, your rivaroxaban, those sort of drugs, because they're slowly replacing warfarin, there's now a lot of focus on the direct or novel oral anticoagulants, depending on what you like to call them. So please try to learn those ones as well. I can't really go over every single thing. We do have a course starting soon, so I'll be going over as many as possible during that time. But if you have any questions, feel free to message me after the session by email, and I can get back to you with more information. Let's look at another question from from Gloria. Gloria is asking how to revise for interactions for clinical. The best book I'll advise you to get is called Top 100 Drugs. Gloria, if you get Top 100 Drugs, this will really, really help you. It would really help you. So it goes over a lot of important drugs. It talks about their side effects, but also talks about their drug interaction. But mind you, for this particular exam, you need to know the implications of the drug interactions. That is something that they've added in recent exams. So for example, let's say we know that two drugs are going to interact, but when that interaction happens, what would happen to the patient? Right, that sort of thing. They want you to know that part as well. So don't just say, right, I know that warfarin is going to interact with fluconazole, for example, or simvastatin is going to interact with erythromycin. Also, yeah, that type of thing. So you need to know what would happen if simvastatin interacts with erythromycin. It can increase the risk of muscle breakdown and rhabdomyolysis. So you need to know it to the end, if that makes sense. All right, so get this book, Top 100 Drugs. It helps for revision as far as your drug interactions is concerned. Right, this one is for Sureena. Sureena, Anesu has a question for you.
Yeah, so how do you bounce back after not passing the exam and build your confidence back? I'd like to thank, I think, is it Caillou, who I actually recognize, who's referred to one of the videos that I've done, failing an exam video. I think what's important to remember is that how you feel about not passing the exam is totally valid. If you're feeling down, if you're feeling underconfident, those are normal things to feel. What's also important to recognize is that there were probably a lot of questions that you got right as well. And it's very easy to beat ourselves up about the questions we got wrong and not consider all the questions we did get right. Reflection is something which I would really recommend that you do. So reflect on what those questions were, what chapters it were, what areas it were that you weren't passing those questions on, but also reflect on those areas where actually, or even, sorry, let me rephrase, reflect on the areas where you felt underconfident going into the exam, but do also reflect on the areas where you felt confident in as well, and try and then focus your revision based on that. So if there were particular areas that you really struggled with, say it was calculations, then that's really where you need to then focus more of your attention on. And remember, you've worked so hard throughout your MPharm degree to get to this point. This is the last hurdle that now you need to get through. And in many ways, having failed the exam in a very strange way puts you at a better advantage, because when you go to sit the exam, it can be quite overwhelming not actually knowing what the setup of the day is going to be like, what the structure is going to be like, what the format is going to be like. But if you've already sat it before and you're going in for your second or your third time, you can kind of alleviate some of those anxieties because you can mentally prepare and see yourself sitting in that exam again. So actually all that it is that you're then needing to focus on is the content of those questions that are coming up. So do refer to that failing an exam video, because I do speak about more sort of hints and tips with helping to have that bounce back feeling. But just because you failed once doesn't necessarily mean that you're a failure, and it doesn't mean that you're going to fail again. You can do this. Have that confidence in yourself, have that belief in yourself, because it does go such a long way. If you want to talk more sort of offline, please do DM me on my Instagram, Sureena Speaks, and we can carry on the conversation there. Be happy to help you. Oh, you're on mute.
Yeah. Thank you so much. Guys, if you have any other questions, you can ask us, but we will move over to the second segment of today's session, which is where we go over some clinical content. Welcome to every single person. I can see some more people have just joined us, and I think more people will be joining in later on. Feel free to share this link, by the way. We're giving out a lot of important, vital, useful information. So feel free to share this link to invite anybody who has failed the exam before, anyone who hasn't sat the exam, they plan to sit the exam this year. Guys, send this link to them, because we need to smash the exam to pieces and also have a great trainee pharmacist year as well. So by using the tips from today's session, hopefully it can improve how people, or the experience of trainee pharmacists during their year. All right. Message from Suk. Suk says, so nice to see you, Mike, on YouTube. Calculations. Thank you so much, Suk. Thank you so much for saying that. I really appreciate your comment. I used to be a maths teacher. I used to teach GCSE students initially, and obviously when I qualified as a pharmacist, I've now moved on to teaching calculations and clinical, but I love calculations. So we'll talk about later on at the end, but let's move on to clinicals and the questions that we have today. Guys, there's a surprise for you. There's a surprise if you're able to get all the questions right today. There is a prize, which is a surprise. I'll announce that at the end if you're able to get all the questions right. So please don't look at your notes. I want you to answer all the questions today from what you remember, what you know. Try and think about it properly before you answer. Part of the problems that people had in the previous exam, or the feedback from the previous exams, is that people rush to answer questions. Don't do that nowadays. Obviously, answer within the time, but have a good think about all the options before you answer your question. All right. So good luck to everybody. Get your notes out, but obviously don't look in them. You can refer to them later on, but get a bit of paper out to write down your answers, and we can go over every single answer once you've written your answer in the comment section. Okay, so I'll give you about 1 minute or so. Don't write your answer until I say right. When I say right, then you can write your answer to prevent other people who are a bit slower from feeling a bit uncomfortable. So we'll have about 1 minute and 20 seconds. And then when I say right, then you can write down your answer and the reason as well, should I add, because part of what we emphasize on our course is for you to know the reason why that answer is correct. So it doesn't look like you've guessed it. So you write your answer and reason. Very important for you to get both of them right. Answer and reason. Okay, guys, time's up. I want you to write your answer and your reason. Give us your answer and your reason in the comment section. Type your answer and your reason. As I say, I'll keep an eye on all the answers. And if you're able to get all of them right, there's a surprise prize for you. And write your answer and your reason in the comment section to this particular question. Guys, if you have an answer, write your answer in the comment section. We do need to go over quite a few questions, so please write your answer as soon as you have that answer. Put it down so that we can go over the answers together as a class and move on to the next question. So if you have an answer, put it down. I can see about 5 answers already, but there's more than 5 people on the live session tonight. So if you're watching, please get involved. write your answer. Doesn't matter if you get it wrong. Guys, we're here to learn. We're here to educate you. If you make a mistake, we're here to correct you and help you along the way. Rome wasn't built in a day. So please write your answer if you have one, regardless of how you feel about it. Just write it down. Okay, so we have answers from Esther. Hello, Esther. I've got an answer from Grace. Grace went for D as well. So Esther went for D. Grace went for D. I've got Vibes. That's a nice name, isn't it? MK Vibes. I like that. Vibes went for D. Thija went for D. Ebby went for D. Suk went for D. Sohir went for D. Nadine went for D. So everyone's gone for D. Okay, so let's go over to Sureena. Sureena, what is the correct answer to this question and why is it correct?
So most of you have picked it up, those that answered. The answer is D. And you have given some good reasons as to why it can't be D. But let's go through more wider rationale and reasoning. Why is D and why it wouldn't be any of the others? So from this case scenario, we know that the patient is obese. Therefore, we wouldn't necessarily give glycoside because glycoside is a sulfonyl urea. I always find that word fun to say because it's quite a tongue twister. And sulfonyl ureas can cause weight gain. And because he's already obese, or she's already obese, that's not something necessarily that we'd want to give. We can't give metformin in this case because the patient's EGFR is less than 30 ml per minute. Therefore, she's at an increased risk of lactic acidosis, and quite a few of you picked up on that. Pioglitazone is another one that would be ruled out because it is contraindicated in patients with heart failure. And in terms of insulin, so don't usually give insulin in the initial stages of type 2 diabetes. That would be later on down the line. So in this case, as most of you have said, it is D, it is linagliptin. And just to reinforce that, it's okay to get questions wrong. It's all right to get things wrong. You learn more from what you get wrong than from what you get right. And especially at this stage, whilst you're still learning, it's okay to get things wrong. So just have a go. Give it a try, put things in the comment box. And if you get it wrong, that's absolutely fine. This is a safe space. There is no judgment and everyone is here to learn. So just go for it. You've got nothing to lose by going for it.
Thank you. Let's move on to question 2. Question 2, you've got 1 minute and about 20 seconds. So as soon as it's 1 minute and 20 seconds, I will stop you and we can go over the answer to question 2. Okay, so guys, let's have the answer to question 2. What is the answer to question 2 and why? I need the answer and why is that answer correct? Answer to question 2 and the reason. We need to know the reason. What is the answer and what is the reason? Write your answer, guys. If you have an answer for us, write your answer in the comment section as quickly as you can so that we can go over the correct answer and move on. So tell us your answer and tell us the reason for your answer. Tell us your answer and tell us for the reason. Get involved. If you're someone who's watching tonight and you'll be sitting your exam in June, I understand everyone is at different stages of their revision process, but do get involved so that you can learn. You learn by getting involved. You learn by asking questions. You learn by making mistakes. Yeah. So don't worry. Don't think anyone is going to judge you for any reason whatsoever. This is about you. This is about you and your ability and to succeed. So get involved if you're watching us tonight. Okay, so let's go over to Sureena so we can go over the answer to this particular question.
So I think majority again have got this one right. Nazifa has put it really well. So it's 20 milligrams of atorvastatin. Statins for primary prevention. 80 milligrams is for secondary prevention. So let's delve into this a little bit deeper. So we know that the Q risk is more than 10% for this particular patient. Therefore, he has a higher risk of suffering from a cardiovascular event in the next 10 years. So Mr. T will need some kind of therapy to prevent that cardiovascular event. So as you mentioned, there's primary prevention and there's secondary prevention. And this question is asking about primary prevention. Therefore, we wouldn't necessarily give something like aspirin, as aspirin is no longer recommended in primary prevention, as there's little evidence of its benefit, but it is still used in secondary. Now, amlodipine and ramipril, they could be used depending on the patient's blood pressure, but we don't know what their blood pressure is. That hasn't been mentioned. Therefore, that's why it leaves us with that atorvastatin. And as beautifully summed up earlier, the 80 milligrams is used for secondary prevention. 20 milligrams is indicated for primary prevention of cardiovascular disease. So that's why the answer is A.
Thank you. Yes. So in addition to what Sureena just said, I just wanted to mention about health risk and measuring health risk using the Q risk tool. Nadeem says he's gone for atorvastatin 20 milligrams because it can be given as primary prevention and Q risk is above 10%. Very good. It's above 10%. But what does that actually mean? If the patient's Q risk is above 10%, it means they have a higher risk of developing a cardiovascular event over the next 10 years. So for people whose Q risk is over 10%, please learn that if you don't know that already. If it's over 10%, it means there's a higher chance that that patient may develop a cardiovascular event. So it might be heart failure, it might be stroke, it may be coronary heart disease, all sorts that are, of course, that can affect the heart can happen or may happen within the next 10 years. So that is also important to know. Moving on to question 3. Question 3 is about a scenario where you're working as a locum pharmacist in a community pharmacy one Saturday morning when a young woman of about 15 years old walks into your pharmacy. They ask to speak to you in the consultation room. She requests for the morning after pill and you proceed to give her a questionnaire for emergency contraception. From the answers on her questionnaire, she actually meets the criteria for emergency hormonal contraceptive. During the consultation, you also notice bruises, scratches on her neck, and a black eye on her face. She totally refuses to speak to you about it. And the question is asking, what would you do next? What is your next line of action? So I'll give you a minute to read that question again and tell us what your next line of action would be if you found yourself in this scenario in real life. Okay, so stop and tell us your answer. Stop and tell us your answer. and tell us why your answer is correct. Stop and tell us your answer and tell us why your answer is correct. Tell us your answer and tell us why your answer is correct. Now let's look at some of the options in the comment section. I have an answer from Magada. Magada went for A or E. Magada, you can't do this in the exam. You have to go for one option. I wish I could do that. If I wasn't sure what answer it was, I would just go for this one or that one, like the Manchester United goalkeeper doesn't know where to go, this way or that way. That is very funny. Magada, please make your mind up. Give us one option. Choose one option. Kwaku went for E. Emmanuel went for A. Esther went for E. Grace went for C. I'm getting different options. Another person went for A. She is being physically tortured, so E. Okay. Another person went for A or E. That is funny. E again. All right. Okay. So let's go over this question properly, guys. This question relates to what we call safeguarding. There's a guideline from the GPHC about safeguarding. If you go on the GPHC website, it talks about safeguarding. When we talk about safeguarding, obviously it affects everybody, but it's mostly related to vulnerable adults and children. So vulnerable adults could be disabled people, for example, or people who have learning difficulties, or people who have mental health problems. They can be classified as vulnerable adults. And obviously children could be anybody who's under 18. In pharmacy, a child is someone who's under 18. All right. But in terms of capacity, which is a slightly different topic, we look at people who have capacity from 16. And then we can assess if they don't have capacity using Fraser guidelines, for example, or Gillick's competence, which is something we'll talk about in a lot of detail later on the course. All right, so let's look at the question. The answer. The answer to this question is actually E. Well done, Ahmed. Ahmed Ibrahim went for E. That is correct. And there are two things there. One of them is the correct drug to supply or not to supply, and your action after you've done that. So we will supply because she actually meets the requirements. She meets the criteria for emergency hormonal contraception. We would give Ella 1 because we know that Ella 1 works up to 5 days. But in her case, we'll give Ella 1 not Levonel because Levonel is licensed over the counter from 16. So Levonel is licensed over the counter for 16, but LR1 we can actually sell to people who are under 16. Okay, so Levonel OTC, unless you have a PGD, but OTC is 16 and above. But LR1 you can sell to someone who's under 16. So that's one point you can learn. The second point is that this patient has signs of possible abuse. Signs of possible abuse. And as pharmacists, we have to get involved. We can't say, well, the patient may be going through something, but that doesn't really have anything to do with us. Our job is to, give medicines out or counsel patients about medicines. Yes, that's our job, but also part of our job now is to help to safeguard or help in safeguarding members of the public, patients who may be at risk. So we're not sure entirely what she's going through, but there's a chance that she could be going through some sort of abuse. And if there is that chance, the GPHC says we have to report to the child protection officer. Child protection officer. So please note this, that in case they change it in the exam from police to child protection officer, it means the same thing. So in the GPHC guidelines, it says report anybody who may be at risk of abuse to a child protection officer or a police officer. All right, that is what we need to do. And they can do the investigation and find out what's actually going on. Are they being abused? Are they not? We're not sure, but that's the job of a child protection officer. Okay, so please note down those points. Someone is saying, Ahmed says, and also the patient refuses to speak. Very good. Or to share what's going on with them. Yeah, sometimes when people are being abused, they're very scared to speak up. They're so trepidated that they can't talk about what they're going through, or they don't want their abuser to get into trouble, and then it sort of like backfires on them. So those are some of the signs of abuse that we need to be able to pick up on and make the right decision. Thank you so much, Ahmed Ibrahim. We're going to move on to question 4. Question 4 is about the MEP, controlled drugs in the MEP. So I'll give you a minute to look at this question, and Sureena is going to go over the answer for us. Guys, stop and write down your answer, and Sureena is going to cover this one for us. Stop and write down your answer. 1 minute is up.
So getting some responses come through. So the answer is B, 1 as directed. The reason being why it wouldn't be, for example, 4 times a day when required or twice a day as required is because that's telling us the frequency, but it's not telling us the dose. So we don't know, is that 1 4 times a day when required? Is that 2 4 times a day when required? It's really vague. And so when it comes to controlled drugs and the prescription requirements on there, it does need to be that bit more specific. 1 as directed is something which is valid, and that is it's a valid thing to have written on a prescription as per the RPS's MEP. As per drug chart, again, that's really vague. We don't really know what that means. And again, when required, it's just too vague. So that's why it's not A, C, D, or E, because all of those are too vague a response. 1 as directed is appropriate. For more information on that, do refer to the controlled drug section on the MEP, where it does give further guidance on what is appropriate and what is not appropriate wording for a CD prescription.
Yes, thank you. Yeah, so this is very important. This is an important part of the exam, guys. If you haven't covered this part of the MEP already, section 3 of your MEP under controlled drugs, it tells you which directions are acceptable for controlled drugs and which ones are not acceptable. All right. So in the exam, 1 as directed will be fine in the exam because it says how many the patient needs to take. So the first option, which says 4 times a day when required, how many are they taking 4 times a day? How many are they taking? 1 4 times a day, 2 4 times a day, 5 4 times a day? It doesn't tell you how many. So the patient can overdose or underdose. So to avoid the patient overdosing, for example, we need to put in instructions or directions that says specifically how many they need to take at a certain time. So 1 as directed is okay because it says take 1 as the doctor has told you. What the doctor has directed them to do is between them and the doctor, but at least we know they're meant to be taking 1 as the doctor has directed them. Okay, so look in your MEP section 3 under controlled drugs to learn all the acceptable directions for controlled drugs. Let's move on to question 5. Question 5 is a scenario for you to read. So please read the scenario and tell us your answer in the comment section. Okay, stop and tell us your answer. Stop and tell us your answer. Also, guys, if you can remember to write your explanation or your reason, it helps us know that you understand why that answer is correct and you're not guessing. So tell us your answer, but also tell us the reason as well, because sometimes your answer is correct, but the reason you've chosen is not correct. It's a chance for us to correct any mistakes before the exam. Okay, so over to Sureena. Sureena will go over this one for us.
Yeah, so most of you have got it. The answer is C, make an emergency supply for 5 days. Grace has summed it up very well. It's a Schedule 4 Part 1 drug, so you can do an emergency supply for 5 days. I think this is a really interesting question because it's a very real life question. I'm sure you've worked weekends and bank holidays, and so the number of emergency supplies for those days, it really does skyrocket. So this is an example of a question where not only does it prepare you for the assessment, but it also prepares you for day one practice as well. So as we mentioned, clobazam, it's a Schedule for Part 1 CD. Therefore, we can give an emergency supply, but the emergency supply must be for a maximum of 5 days. And with a question like this, and with questions that could come up in the assessment, there may be situations or questions where there is more than one appropriate answer, but it's really about finding what is the most appropriate answer. So if we look at something like option E, referring him to the local hospital, that's a fair shout, but it's not the only way that he can get a prescription for a CD. NHS 111, for example, would be another potential route. So really make sure that you're reading those questions carefully and really thinking about the answer before selecting your option.
Just going over the comments from some of our trainees tonight. Someone says, not a CD, so you can give it. It's actually a CD. Vibes is a CD, but it's a CD Schedule 4 Part 1, which we're allowed to give emergency supplies for. So remember that we're not allowed to give emergency supplies for CD Schedules 2. We're not allowed to give emergency supply for CD Schedule 3, except phenobarbital for epilepsy. If phenobarbital is going to be used for epilepsy, then we can give up to 5 days of phenobarbital, even though it's a Schedule 3 CD. But for Schedule 4 Part 1 or Part 2 and Schedule 5, we're actually allowed to do emergency supplies for those ones for up to 5 days. Another person makes an important point I would like to clarify. I've got a question from, yes, so Farmi says, as he is a regular patient. Yes, so nowadays there's something called SCR. I'm not sure if you've heard of this, Farmi. So SCR, Summary Care Records of a Patient, allows us to be able to access information. As a trainee pharmacist, I don't think you have the ability to do so, but once you go on the register, your local CCG, the IT department of your local CCG, can add that function to your smart card, and you'll be able to access SCR for a patient. So nowadays, it doesn't have to be a regular patient for you to be able to give them an emergency supply. What you need to be able to establish is that this is somebody who has been taking the medication on a regular basis. Maybe they traveled from Scotland to see a family relative in England, or maybe they've traveled to Ireland and you work in Ireland from here and they've left their medication at home, you see. So they don't have to be a regular patient in real life. They don't have to be. Obviously, in real life, you can sort of like do things based on other information that they're presenting to you. But for your exam, they want you to go by what's in the MEP. And what's in the MEP says, once you're satisfied that this patient is someone who's taking the medication on a regular basis, or they've had it recently, you can make an emergency supply for Schedule 4 Part 1 drugs for up to 5 days. I'll leave it there and move on to the next question, which is question 6. Yes. Kwaku says quickly, says, yes, if NHS 111 was in the options, would this be right as well? Yes, it would be okay, but that's not the only way they can get that medication. Because sometimes what they do in the option, what Sureena was saying earlier, is they would tell you that the patient can contact 111 because that's the only way they can get clobazam. That's not the only way. So read the entire sentence, because they try to be tricky in some cases by adding other things that contradict the beginning of the sentence. Hope that makes sense. Let's move on because of time. Question 6. This one is a 1 minute question. You literally have to read it and write down your answer. Read and tell us what the correct answer is. Yes, yes, yes. The answer is B. B is clinical governance. B is clinical governance. So please know your definition for clinical governance, know your definition for clinical trial, know your definition for clinical audits, know your definition for medicine optimization, know your definition of medicine's reconciliation. You need to know those definitions, guys. You need to know those definitions because in the exam, they ask you things that are outside the BNF, outside the MEP, outside your OTC books, etc., etc. So some of this stuff comes from the PSNC website, and they expect you to know some of those things. I will cover these things when we start the 29th. But for anyone who's watching tonight, please know your definitions for all of these. Clinical governance tends to come up quite a lot in the GPHC exam, so that one you have to know. So B is the correct answer, and we'll move on to the next question. Question 7. Question 7, read the question and tell us your answer in the comment section. Okay, stop and write down your answer. Stop and write your answer. All right, so let's go over to Sureena. Sureena is going to go over this one for us. Over to you, Sureena.
So I think most have got the right answer. So I think first we need to establish, is the patient conscious or not conscious? So the fact that she's clutching her chest and neck, she's not able to speak properly, indicates that she is conscious. Therefore, performing CPR, which a few people have put in, that actually wouldn't be an appropriate response because CPR is given if you are unconscious. So in this instance, the right answer is C. So you would ask the mother to give up to 5 back blows, hit her firmly on their back between the shoulder and the blades. So when it comes to choking, back blows are usually the initial option to go with. After that, it would be abdominal thrust, but it's abdominal thrust around the waist. Option D mentions around the neck. So again, it's really making sure that you're reading the questions and the responses or options properly. So that wouldn't be the option. And then the final option would be to dial 999. So just to recap, be back blows, then abdominal thrusts around the waist, not around the neck, and then dial 999. So option is C.
Yes, thank you. So option is C, and we'll move on to the next option. Hello, Isam. Isam just made a comment in the comment section. I remember you, Isam. Hope you're well. You've passed the GPHC exam and you've registered. Yes, very nice to hear from you. Let's move on to, I've actually got a comment from someone else as well. Someone says, she is still breathing, so CPR is not appropriate. Abdominal thrust not recommended in children. Depends on the age. It depends on the age of the child, Kate Evans. Depends on the age. If you look at the guidelines, it depends on the age. Yes. All right. Let's move on to question 8. Question 8 is this question here that I want you to read. Take your time, read this question, and tell us what the correct answer is. Okay, guys, give us your answer in the comment section. Write your answer. Write your answer in the comment section. Write your answer in the comment section. Question 8 says, Mrs. Johnson, a 50-year-old female, presents you with a prescription for digoxin 125 micrograms once a day. This is a new medication that's just been prescribed to manage her atrial fibrillation. You check Mrs. Johnson's PMR, that's patient's medical records, and notice that she regularly takes ibuprofen, Bendro, and codeine tablets. Which of the following statements is the of most concern? Guys, you need to highlight that. Most concern to you. Let's see the answers that people have put down in the comment section. One answer from Kiba Isa. Kiba Isa went for D. Says D can lead to digoxin toxicity, which is fatal. Yes, I agree. Another person went for A. Another person went for D. So he went for D. Anesu went for D. Esther went for D. HA went for C. So the correct answer in this to this particular question is actually D. D is the correct answer. D is the correct answer. Why is D the correct answer? D is the correct answer because the patient takes a diuretic, benzoylflumethiazide. And what this diuretic can do is increase the risk of hypokalemia. It increases the risk of hypokalemia. And as you know, hypokalemia is one of the electrolyte imbalances that can lead to digoxin toxicity or digoxin digitalis. All right, so hypokalemia is one of the electrolyte imbalances that can lead to digoxin digitalis. But there are 4 in total. There are 4 electrolyte imbalances that can lead to digoxin digitalis. 4 electrolyte imbalances. The first one is hypercalcemia. Hypercalcemia. So that's high levels of calcium. Hypercalcemia. hypercalcemia. The second one is hypokalemia. The second one is hypokalemia. So that is low levels of potassium. The third one is hypomagnesemia. Hypomagnesemia, which is low levels of magnesium. And the last one is hypoxia. Hypoxia means low levels of oxygen. Okay, so those are the 4 electrolyte imbalances that can lead to digoxin toxicity. Hypercalcemia. So hypercalcemia is the only one that's high levels of calcium in the patient's system, low levels of potassium, low levels of magnesium, and low level of oxygen. Okay, so those are the 4 you need to remember for the exam. And also, as part of the new exams, they want you to know things that would lead to these electrolyte imbalances. You see, so we need to know drugs that will cause hypokalemia, for example. Can anyone tell us in the comment section, can you tell us about 3 drugs that can cause hypokalemia? There's so many. I know about 10 by heart personally, but I need 3 from you. Don't tell us about Benadryl because I know about Benadryl. Tell us 3 other drugs that can cause hypokalemia. Hypomagnesemia, I know something like PPIs can cause hypomagnesemia. Someone who has chronic asthma, actually acute asthma, is more likely to have hypoxia in some cases, and we have to give them oxygen. Or a very bad case of COPD, they might end up with hypoxia. But tell us about hypokalemia, which is a very common one. 3 examples. I just need 3 examples, guys, so we can move on. 3 examples of drugs that can lead to low levels of potassium. 3 examples. I just need 3 examples of drugs that can lead to low levels of potassium. Tell us in the comment section. Tell us if you only remember 1, tell me 1. If you remember 2, tell me 2. If you know all 3, tell me all 3. Low levels of potassium. Tell us in the comment section. Low levels of potassium. Tell us in the comment section. Okay, so without wasting time, a very good one is theophylline. Theophylline is a narrow therapeutic index drug. That is a very good one. Another one is a drug like salbutamol. Salbutamol can also cause, beta agonists can also cause low levels of potassium. Corticosteroid, yes, including inhaled corticosteroids. Inhaled ones can cause, as well as the oral ones, can also cause potassium loss. Remember that we have 2 types of corticosteroids. So we have the glucocorticoid and mineralocorticoid. One of the problems that mineralocorticoids would cause is potassium loss. So remember, sodium retention, water retention, potassium loss. Yeah, because when sodium goes in, potassium goes out. So remember that. So those are very good examples. There's loads. I know so many, but remember these ones for today. Let's move on to question 9. Question 9 is an OTC question. You literally have 1 minute for this question. 1 minute, and Sureena is going to go over the answer for us. Read and answer in 1 minute. And tell us why as well. Please tell us why you've chosen that particular option. Okay, that's 1 minute up. Let's go over to Sureena. Sureena, please go over the answer.
Yeah, so I think quite a few of you have given the right answer, but also the right reasoning as well. So with a question like this, we want to look at actually how many toes are affected, because knowing how many are affected will actually depend on what option we go for. So with this one, the answer is C, refer her to her GP. Reason being because more than 2 nails have been affected. So if more than 2 nails are affected, they need to be referred to the GP and then prescribed. We can see it's a fungal nail infection. If, however, 2 or less nails had been affected, then that can be treated in community pharmacy, in which case the answer then would have been D, to sell her a morphine. Never like saying that one. But yes, because it's more than 2 have been affected, that is the reasoning why she would need to be referred to her GP.
Okay, let's move on to question 10. Question 10 is on asthma. Question 10 is on asthma. Again, we have about 1 minute or so for you to read and answer this question on asthma. Okay, so that's it. Time's up. What is the answer to this question? Write your answer, and let's go over to Sureena. Sureena, you can cover the answer for this one.
Yeah, so with this one, the answer is actually B, so it's to add on a LABA. So with asthma guidelines, there are NICE guidelines and there are BTS guidelines. And for the registration assessment, you are expected to know both, and you're expected to know where the differences are between the two. So if we start off with age, NICE guidelines recommendations for adults apply to those aged 17 years and over. Whereas with BTS, recommendations for adults apply to patients aged over 12 years. BTS guidelines also favor the initial add-on therapy of a long-acting beta agonist, so a LABA, whereas NICE recommends a leukotriene receptor antagonist, an LTRA. So with LTRAs, they are usually effective in people who have an allergen. So say their asthma is spurred on by dust or during hay fever season with a high pollen count, that then makes their asthma worse. It makes them hard for them to breathe. LTRA is effective. And that's what NICE guidelines say. Whereas with BTS, they prefer a LABA because it acknowledges that not everyone's asthma is going to be triggered by an allergen. And so its recommendation for initial add-on therapy is a LABA. When you get if in the exam you do get a question like this, the GPHC will state whether they want you to refer to NICE or they want you to refer to BTS. I do actually have a video comparing NICE versus BTS. So if you go onto my YouTube channel, you type in Sureena Speaks, NICE versus BTS, that will come up. So for this one, the answer is B.
Yes, thank you. So the correct answer is B, and you also need to know some more. I've just written that down in the comment section. If you're watching, just have a look at the comment section. I've written down a couple of points that you also need to remember as far as the differences between NICE guidelines and BTS guidelines. Thank you, Sureena. Let's move on to question 11. Question 11 is a question about side effects. It's a question about side effects. Very straightforward question. Have a look, 1 minute, and tell us what the answer is. Okay, so let's look at the answer to this one, Sureena.
Yes, so the answer is C, chloramphenicol. Chloramphenicol is the one that is associated with grey baby syndrome. It is more likely to happen with IV or with oral treatment than it is with topical, so for example, eye drops, but it may be absorbed systemically following the use of eye drops, and then there is potential for it to cross the placenta and appear in breast milk. So that's why it's not sold or for use in pregnancy or lactation over the counter. So if a pregnant woman approaches the healthcare counter and asks for chloramphenicol, that's not actually something we can give OTC. They would need to be referred. It's also worth noting that grey baby syndrome is most likely to occur during the third trimester, and that's especially the case in terms of IV or oral use.
Thank you. Sureena, we do have a couple of questions from the last question. Asthma is obviously a very important aspect of pharmacy and of the exam. I have two quick questions. So what I'll do, I'll answer one of them and I'll let Sureena answer the other one. So one says, when would you increase the dose of ICS? Saba Akhtar is asking about when would you increase the dose of ICS? So let me answer this one. You would increase the dose of ICS after you've given. So in the last example we looked at, the patient had to be given a LABA according to BTS. So after giving that LABA, then your next step would be to increase the dose of the ICS. So for an adult, we can increase up to the maximum. So let's say they were taking Clenil, for example, we can give them we can go from Clenil 50 to 100, from 100 to Clenil 200, from 200 to 250. All right. But if it was a child, that's over 5, according to BTS, we can only go up to 100. If the child is under 5, we can only go up to 50 micrograms of Clenil, for example. It's a lot you need to read to have a good understanding of it, but that's just a short summary. So you would normally increase ICS after you've added the LABA. If you was going through NICE guidelines, you add your LTRA like Montelukast, and then you would increase your ICS. So that is the answer to your question. Say the step after adding your LABA according to BTS. Let's go to Sureena for this one. It says, how come you give 3 inhalers at the same time to some? Do some patients take use more than 2 inhalers, 3, 4 inhalers, etc.? That's what this person is asking. Ahmed Ibrahim. Let's go over to Sureena for this one.
Yeah, so if, for example, you have a patient who's if they're on salbutamol, so they're on a short-acting beta agonist, they might also be on an ICS and they might be on a LABA. Now, good practice would be that they were prescribed a combination inhaler. So the ICS and the long-acting beta agonist inhaler is given together, and that's to do with patient compliance and adherence. So if a patient is using or relying on their salbutamol inhaler, that's really when then they need to be referred to their GP or to have an asthma review, because that isn't something that they should be using on a regular basis. If an inhaled corticosteroid and a LABA isn't benefiting their asthma, isn't controlling their asthma, then their asthma treatment would need to be stepped up. So I'm hoping that answers your question. If not, please do add it in the chat and I'll try and clarify more. But the BNF does state step by step exactly what the differences between NICE and the differences between BTS are, and gives that stepwise approach about what needs to be given in what situation, what's initial add-on therapy, etc. So do have a look at that. That resource is there. Be proactive, utilize it, and do have a look at it.
Thank you. Let's move on to question 12. Question 12 is another straightforward question. Well, straightforward if you know the answer, but spend 1 minute, please. Spend 1 minute on this particular question. Which of the following drugs can also be used to treat infertility in female patients? It's straightforward if you know the answer. Okay, let's look at the answer to this question. The answer to this question is B. B is the answer to this question. It's quite impressive to see some people actually know the correct answer. Tamoxifen, yes, tamoxifen is the correct answer to this particular question. And it can be confusing if you've just heard this for the first time, because you normally associate a drug like tamoxifen with the treatment of breast cancer. But guess what? Quite a lot of drugs have multiple indications, and that's part of the GPHC exam syllabus. That's part of the framework. You need to know the indications of common drugs. Tamoxifen isn't like the most common drug, but a very common one would be something like metformin, for example. So if I ask you, what are the two indications of metformin? Are you able to tell me that? What are the two uses of metformin? Are you able to answer that in the comment section, please? If you know the two uses of metformin. What are the two uses of lactulose? Lactulose can be used to treat constipation. It can also be used to treat what? What is the other one? So quite a few of the drugs that you come across have multiple uses, and as part of your trainee year, you should try to double check or look in your BNF to see what that drug can also be used to treat. Some drugs like citalopram, for example, have about 3 or 4 indications. What are those indications, you see? So try to learn other indications. Okay, so let's look at yes, so let's look at metformin. Metformin can be used to treat diabetes and polycystic ovary syndrome. Fantastic. Diabetes and polycystic ovary syndrome. So if you see a prescription for somebody who is female and they're on metformin, don't assume the person is diabetic. They can be using that to treat polycystic ovary syndrome. Okay, so don't assume, because metformin has multiple uses. Lactulose, another common one, can be used to treat constipation. It can also be used to treat hepatic encephalopathy. What's hepatic encephalopathy? It's a liver disease that can affect the brain. So what happens is your liver produces toxins as part of the disease, and if those toxins are not, you don't get rid of those toxins from the body, they can then travel through your bloodstream and affect the brain. It's called hepatic encephalopathy. Okay, but back to our question on tamoxifen. With tamoxifen, it can be used to treat breast cancer. It can be used to treat anovulatory infertility. So anovulatory infertility means that the patient is not releasing eggs every single month like they would normally. So we'll give them tamoxifen to try and stimulate the release of eggs. But the issue is, if a patient is going to be put on tamoxifen to manage anovulatory infertility, the doctor will normally put them to one side and say, look, if you decide to take this drug, you might end up having multiple babies. So I know you only want the one child, but you might end up having twins or triplets. So be careful what you wish for. Okay, so that's something we need to remember just in case it pops up in the exam. They like to ask strange questions. They asked a question about baclofen 2-3 years ago. No one was expecting to see baclofen in the exam, and it came up. So I will bring up some of these random questions just in case they come up in your exam. Question 13. Read question 13 and answer the question, please. Question 13. Read Guys, stop and write your answer. Stop and write your answer to this particular question, question 13. Write your answer, and Sureena is going to go over this one for us. Tell us what your answer is for this question, please.
So with this question, a lot of people have put C, and I think this is a case where we really need to make sure that we're reading the full question before looking at the options. So the answer is actually E, referring him to a doctor. Reason being is that sumatriptan, if a patient takes a tablet and it makes a difference, so their symptoms of migraine subside, then they can take another tablet 2 hours after. That's all well and good. But with this case, our patient has said that they took it 3 hours ago and it's made no difference. And that is the case with sumatriptan. If the first tablet didn't make a difference, then they shouldn't take a second tablet. And then the next appropriate action is actually that they should be referred.
Yes, thank you. Yes, so in summary, if the first tablet makes a difference in their migraine, so if it makes them feel better, if they feel like the migraine, they took the first tablet and migraine goes away and it comes back 2 hours later, then they can take the second one. Does that make sense? Because the first tablet did make a difference. It did make the migraine go away, but it came back. They can take another tablet at least 2 hours after the first tablet. But if they take the first tablet and it makes no difference whatsoever, if it doesn't touch the migraine at all, the migraine hasn't moved an inch, then they have to be referred. They can't take the second tablet because the first one didn't work. Does that make sense? That is very important. That is a trick they can play in the exam. Sometimes they will ask you the first thing that Sureena just said, or another time they can ask you this, which is send them to the GP because the first one hasn't worked. Okay, so that is something you need to understand properly, both during your practice and for the exam as well. Let's move on. Question 14. Okay, let's go to Sureena. Sureena, this is your question. We'll let you.
Thank you. So the answer is B, enalapril, which is an ACE inhibitor. So a few of you have put it in the comments, which is really good to see. So the patient is presenting with angioedema. So ACE inhibitor-related angioedema is a serious and potentially fatal complication, which is relatively rare in the general population, but it can be more common, it's more common amongst Black African or Afro-Caribbean patients. So if you think back to your hypertension pathway and think of what are the first-line treatments for patients who are Black African or Afro-Caribbean, first line is a calcium channel blocker, not an ACE inhibitor, and it's for this reason. It's important to be aware what angioedema can look like. So it can be characterized by swollen lips and a swollen tongue, swollen hands and feet, and even the areas around the eyes. In general, when you're learning about different conditions, particularly those that affect the skin, I'd really highly advise you look up images to see what that condition looks like on different skin tones. So, for example, what does measles look like, and how is that different to chickenpox? What does slapped cheek syndrome look like, and how does that present differently to scarlet fever? Because the registration assessment can do exactly this, as someone has already pointed out. They can show you an image and ask you to identify what is this patient may be suffering from. And equally, as a qualified patient, a qualified pharmacist, if a patient presents to you with something on their skin, it's important that you can differentiate it from one condition to another. So I would really advise that when you're learning about these different conditions, do look them up, do look at how they present on different skin tones, because there can be variations.
Question for you, Sureena. Gita is asking, says, if someone has angioedema, what would you do? Would you refer them to the GP? What sort of advice would you give to somebody who has angioedema?
So it depends on how much it is affecting them. Chances are if they are Black African or Afro-Caribbean and they're on an ACE inhibitor and they're presenting with angioedema, then they should be referred, and then the GP can find them an alternative.
Yeah, so we refer, guys. Angioedema can be an emergency. In some cases, it can actually affect the patient's ability to breathe. So refer that patient. Yes, refer the patient. Let's move on to the last question. The last question is this question here, which you need to use this picture to answer. So what I'll do, I'll let you have a look at this picture. Just have a quick look at this picture, have a mental image of it, and we'll go over to the actual question that's regarding this particular question. So just have a quick look. A worried mother comes to your pharmacy and shows you her 6-year-old symptoms. All right, so that's the image, and this is the question. So this is the question. If you need me to go back for you to have a look at that picture again, I can do so, but read the question and see if you can answer the question based on that image that you've just seen. Okay, so tell us your answer in the comment section. There's 5 options. Tell us the answer. Okay, so let's look at this particular question. This is our last question for today. Someone is asking a question. The video is paused. The video is not actually Zareltro. Is that your real name? Zareltro Lixiana. Brevoroxaban. Is that your actual? No, it's not paused. Just refresh your link, and it should be fine. All right. So this is the picture of the patient's face. The mother comes to your pharmacy and shows you their child's face, a 6-year-old, and they've got what? Slapped cheek syndrome. Slapped cheek syndrome. So this is what it looks like. This is what Sureena was saying earlier. Sureena was saying, have a look online to see what the conditions actually look like. So when you hear slapped cheek syndrome, you need to be able to identify it when you see it in real life or even in the exam. Okay, so The next thing is, which of them is the correct answer? Now, if you look in the comment section, you see that somebody has gone for A and some people have gone for E. You see, someone says, yes, they agree it's slap cheek syndrome, but they would refer to their GP. And other people, the vast majority, including Magda, well done, Magda. Magda's gone for E, says the boy is suffering from slap cheek syndrome, but should be given paracetamol and antihistamine syrup. Yes. So E is the actual answer. E is the correct answer because slap cheek syndrome is self-limiting. It's self-limiting. As far as there's no other red flag symptoms that the patient has presented to you, you should actually try to manage it over the counter. So give them analgesics, give them antihistamine, maybe a cream like aqueous cream to sort of like soothe their skin if they're feeling uncomfortable, or an antihistamine cream, that sort of thing. So we tend to manage it over the counter first because it does go away on its own after some time, you see. And so if there's no sign of red flag symptoms or referral symptoms, we need to manage it over the counter before sending them to the GP. So the next thing you should do is to manage this over the counter by giving paracetamol and antihistamine. So that is the correct answer. E is the correct answer. E is the correct answer. Okay, so guys, thank you so much for joining tonight. I understand some people have obviously like family commitments or around their kids, etc., etc. But I'm actually happy that you have managed to join. Whoever hasn't managed to join tonight will be able to watch later on, but they won't be qualifying for the prize, which is a lovely Nando's dinner. So I'm going to look at the comment section and see if anybody actually got all the questions right. And if you smashed all the questions right, you'll be getting a voucher for a free Nando's dinner, which I'm sure you enjoy because I love Nando's. I'm addicted actually to Nando's. I love Nando's with all my heart. So I'm going to look, and I will be messaging you later on. And if you wanted to get in touch with us for any reason at all, regarding anything we've discussed tonight, obviously we don't have unlimited time. You can reach us through any of these contact details. Sureena, how can we reach you, Sureena, if the students want to and they want to follow you on social media or etc., etc.? Can you please tell us how students can reach you? Guys, please follow Sureena on Instagram. Follow Sureena on Facebook. I think she has a Facebook group. Follow Sureena on Facebook. Where can we find you, Sureena?
It's Facebook, Instagram, Twitter, TikTok, but less so because it's a bit of a devil app. You know, when you start on it, it's really hard to stop. So I tried to control and manage how often I go on there. But it's all at Sureena Speaks. My YouTube channel, everything is all at Sureena Speaks. So would be lovely to connect with you all. So do feel free to connect and drop a message. And good luck with your training year.
Thank you so much, Sureena. It's been a lovely, lovely time with you on today's session. Guys, please give us a like. Smash the like button. Click the subscribe button, guys. Please, Sureena also has a YouTube channel. I've put the details on the description area. So if you wanted to have a look later on, you can also subscribe to Sureena's YouTube channel. She has a lot of very good content on there as well. And thank you so much for joining. We do have a course starting on the 29th of January, intensive GPHC exam course for anyone who hasn't joined. I've had so many people register already. They didn't waste any time. But the deadline is on the 17th, which is also my birthday. All right. So 17th, which is Tuesday, is my birthday. I'm going to be going out, enjoying myself, having a lovely time, eating, doing all sorts. So that is also the deadline for registering for anyone who wants to join. 17th, my birthday, is the absolute deadline. I would like to thank everyone once again. Thank you, Esther. Thank you so much, Esther. Thank you, guys. Thank you so much for joining tonight. We will end the session now, so everyone can go rest. And I hope and wish you have a lovely week. Thank you so much for joining. If you have any questions, any inquiries, please feel free to reach us. You can go on our website. You can message me on Instagram, etc., etc. Thank you so much, guys. We'll end the session now, and I'll speak to you very soon. Bye, Sureena.
Thank you so much for inviting me. Take care. Bye.
Bye. Bye.